Hi, and welcome to episode 5 of The Skin and Stitch, a podcast following two friends in their journey through medical education. I'm John, and today I will be interviewing Dr. Ann Kim, an internal medicine physician at the San Francisco Department of Public Health. Her nonlinear path to medicine took her to Stanford University and UCSF Medical School. She completed her training at UCSF and continues to live out her Christian calling to serve the poor in a San Francisco neighborhood clinic. Without further ado, I'd like to introduce our very first physician guest and someone I greatly admire. I'm going to introduce Dr. Ann Kim, who is an internal medicine physician in the San Francisco Department of Public Health, and whose primary practice is in a small health center in the Western Addition neighborhood of San Francisco. But I know her because she is one of my biggest mentors in medicine and a big inspiration for me in terms of how to put the care of my patients first. And inspiration is even putting it lightly. So I'm really excited to speak to you. And you're the first doctor that we're having on the podcast. So really excited.
Thanks, John. You're an inspiration to me too.
Thank you. I'm sure that's not true, but
it is true.
Well, I'm glad I'm inspiring some people. So my first question for you would be, if you could just tell us a bit about your journey into medicine, maybe how you grew up or how your early experiences shape your decision to become a physician. And I know I'm asking this because you had a pretty interesting and nonlinear path to medicine. So if you touch on, that and also where you ended up training and your experiences there, that would be great.
Sure. It was non-linear. I am the first U.S. citizen in my family born here. My mom was pregnant when she immigrated, and I grew up in Oregon. And from the time I was in maybe middle school, early high school, I thought I was going to be a cellist. So I was really into my cello, and I went to music school at Oberlin, and I had a pretty significant experience my freshman year of college. So I was 17 and then 18 and just had a spiritual experience where I felt a call to serve the poor. The long and the short of it was, and I didn't so much have the imagination for how to do that with classical music. So I just started exploring other pathways and was pretty drawn to medicine early on, which led me to transferring schools because I went to Oberlin for the Conservatory of Music. So I ended up at Stanford and crafted a major around kind of poverty and medicine, and still wasn't totally sure. Thought I might do social work or was looking at other areas. So after college, I worked in sexually transmitted disease control, is what it was called in the 90s. And then I felt pretty confirmed that I wanted to go into medicine, but it was circuitous for sure.
And then you ended up, where'd you end up for medical school and your residency?
Yeah. So by then I had moved with some friends to San Francisco. We were living in community, and we were part of this little church in the Mission called Grace Fellowship. And I do remember some older women. One nurse in particular, she's passed now, but she said, "I'm going to pray that you can stay here." And she did. And I did get to stay here. So I did medical school at UCSF and residency also at UCSF at the San Francisco General Hospital-based primary care internal medicine program. And I've been here ever since.
I know, and I'm lucky that you have because I got to meet you. But was there a pivotal moment that you decided to go towards primary care especially in a community-based setting, as opposed to specialty?
I'm not sure if it was just one moment, but I've always been drawn to direct interactions with patients, and the patient relationship is, I think, what has kept me in medicine all these years. And so it sort of made sense over time that primary care was where I could have relationships with patients over many visits, which can turn into many years. And sure enough, at this point, I've had some patients for 20 plus years. And that, like, a patient passed a couple weeks ago, and her daughter said, "Your family." And so that's why I keep doing what I do. It's such a great privilege to become like family with patients.
Yeah, that sounds really rewarding. And I'm wondering, you brought up that you're the first child of your immigrant parents. And was there any sort of struggle or any, I don't know, point of tension when you told your parents, you know what, actually, I've been working towards becoming a cello player, but now I'm not so sure, but I know that I want to serve the poor?
Yeah, there was tension all around. I have to say, I'm not the type of person who tends to shy away from tension. And so the whole like music thing was really hard on my parents, right? They're like, "Oh no, she's gonna be a musician. That's crushing." But
So maybe they were happy when you said, "I want to become a doctor."
Exactly. My dad was a veterinarian in Korea. He was a large animal vet. And then when they immigrated here, he was told he'd have to repeat veterinary school in order to practice. So he didn't. So there was already somewhat of a loss, I think, for my dad. And then, yeah, my poor parents, my sister had already gone the direction of wanting to be like a missionary pastor. And then their second child, there's only two of us. I wanted to be a musician. So I can only imagine what they're thinking, these poor immigrants. But so then when I came back and said, well, I'm kind of rethinking the music thing, and I want to serve the poor, and maybe I'm interested in medicine or healthcare, I think my dad was just trying to keep his relief under wraps. But I was also so contrary that I was kind of like, but it's not to make money, and it's not for security. It's because I want to serve the poor. And he was kind of like, all right, that's fine, whatever.
As long as you leave the conservatory.
Right. And, have a stable job and maybe health insurance someday.
But it turns out that you still get to practice your music, and it's still an outlet for you because you are part of the worship team at church. And
yeah. So it is kind of nice how things come around. That's been really fun.
So I'm wondering it's probably along the lines of serving the poor, but what drew you to public health, specifically in the neighborhood clinic? Because you've done your residency at the General, which is also a safety net institution. Actually, the UCSF works with SFDPH, I think, and is also safety net institution. So what about the small size of the clinic were you drawn to?
Yeah, I work at Maxine Hall Health Center, which is in the Western Addition. And there's so many things about my clinic that I really just love. I'm not sure if it's the smallness, but maybe that's some of it. You can kind of go deeper with staff relationships in particular. But right where we are in the heart of the city, it's kind of my window to the world. I have patients who are Black patients who've been in the Fillmore for multiple generations. I got patients from the Ukraine, from various parts of Africa, from China and Korea, and just all over the world, and having super different experiences. So I really love that, the diversity of the patient population. And I kind of do love too that, like just today, walking through the waiting room, a patient will grab my hand and want to chit chat. I don't love it all the time, honestly. Sometimes I'm like, I gotta go. But there is some of that community feel and that I really do cherish as well. Sometimes patients will just kind of stop in to say hello, and not just to get their healthcare. So that it feels like it's been a community hub for quite a while. And to be part of that small community has been really great.
Yeah, that's great. And I'm wondering if you've seen any differences because you've worked there for quite a long time, like changes in your patient population. Have you seen any trends with that or?
Oh yeah, for
No.
sure. I mean, our clinic kind of gets the reflection of what's happening in the city overall in terms of, say, the housing crisis and just overall, San Francisco's lost so much of our African American population. And we feel that especially in the Fillmore. Fillmore used to be called the Harlem of the West. It's really vibrant, historically Black neighborhood. And we've just lost so many people. So a number of my African American patients were, moved out to the East Bay, different parts, but they would still come back for their primary care. But it's really rough. I've explicitly had multiple conversations with patients saying, I think we need to find you a doctor in Antioch or Pinole or Stockton even. It's too hard for you to come back and forth and get your care. The Fillmore has also been Japantown, so a very Asian American population as well. We've seen fewer and fewer Japanese American patients for sure. I only have a couple now. More and more, I would say Korean, definitely more Ukrainian patients. But the mix will change over time. And then some of the patients, based on our provider group, like we have my colleague who speaks fluent Arabic. And so most of our Arabic patients go to her and such. So some of the, I don't see the full mix of patients. A lot of the Koreans find me because my last name is Kim. But I still try to, I actually have 2 Arabic speaking patients and a handful of Spanish speaking patients who, even though my Spanish is terrible, I can't let go of them. So.
Right. Yeah, I'm hoping my Spanish comes into use someday too.
Oh yeah, keep up with the Spanish. That's huge.
So I know that your longitudinal patient relationships, as you said, are something that you really value, and you've just brought it up. I could definitely tell from my time shadowing you. You instilled on me how important that was, and I can see also the effects of that in the trust that your patients have in you. So could you tell us a bit more about why that's so important for physicians to have?
Yeah, I really, it's an interesting time. I don't know what AI is going to do. I think it's going to do a lot. And I think the shape of your career, John, is going to end up looking pretty different than mine. I don't think it's all bad. I'm very curious and kind of excited. But what I do know and what I hope carries over is that the primary care relationship, and I think the doctor, and not just doctors, nurse practitioners and physicians assistants too, but the provider-patient relationship there's something about the relational basis of that relationship that's part of the healing equation that I don't think AI will ever replace. Mm-hmm. There's something about the journeying together, bearing witness one human to another, partnering together and kind of being on the same team together that does translate into healing in in a way that, I mean, maybe it's replicable, but I'm not sure how. I'm thinking of my patient who just passed a couple weeks ago, and she was in her 90s. She led a really good and full life. But I've gotten to befriend her daughter. I got to know her son right at the end. I went to visit her in her home, which is just a few blocks away from the clinic, and met others of her relatives. There's something about knowing each other and trusting each other that I think has been healing for, I hope her, definitely for both of us over time. And I think translates to something broader in the community as well. She went through, so she's African American, and when COVID came down, she was super cautious about her health. But she had a lot of distrust of vaccines, which was not uncommon, especially in the beginning in her community. And so we talked about that a lot. She ended up getting COVID and was hospitalized for a long time and almost died. This is back in early days of COVID. And when she came out, after a long period of, being in a nursing home and all of that, we had some really frank conversations together. And she was so with it mentally that she remembered our conversations about vaccines before her hospitalization. And she was like intubated in the ICU and the whole thing. Oh. And she wanted to revisit that. And in fact, she said things like, I'm telling all my friends to get vaccinated. I don't want what happened to me to happen to them. And I trust what you're saying. I trust what you're telling me. And I want things to be better for my community. So I feel like that whole arc and transformation really couldn't have happened without a trusting relationship that we were grounded in. She ended up not passing up COVID. She passed from other things, but and actually she did get a lot better, which is impressive because she was already in her 90s when she got COVID. But those types of interactions, it's not something that AI can generate. It's not something that a public health service message can generate. I think it was really rooted in our relationship and our journey together.
Yeah, actually, one of the core memories I have of shadowing you at Maxine Hall and learning from you was after one of the patient visits, you gave me an assignment to look up the Tuskegee study and just to understand how history and historical practices in this country in the medical field have affected people's trust, especially of health that's connected to the government. So I'm wondering if your family purposefully moved to the Bayview neighborhood, which is historically Black, to be more connected and grounded with the community that our church is in. But I'm wondering if that's helped you connect with your patient population.
Yeah, that's a great question. I think so. I think it's all tied together for me. Definitely my family was we were motivated to move into the Bayview after our church, Redeemer Community Church, decided it was going to be rooted in the Bayview. And so that made us feel like, yeah, we want to be rooted there too and care about the neighborhood in a way that I think would make sense for us to care about if we were just living there.
But you can only care about it if you live there.
Yeah, kind of that way. I mean, I don't think that's totally true because I think a lot of people in our church care about the Bayview
I guess
too.
There's a special way that you can care about it by being there.
For sure. There are also some just natural connections between the Bayview and the Western Addition. Um, I have lots of patients who come in from the Bayview, and I've seen, um, there's just a lot of back and forth. I think because it is the two major historically Black neighborhoods in San Francisco. But I think it gives me a deeper sense of place, as well as just maybe a deeper sense of injustice, like with environmental racism and just places that are best forgotten by a lot of other people. That's not tended to left off the tourist maps, that type of thing,
Yeah. Sorry if you can hear that in the background. My dog's drinking water.
Ah,
But my co-host couldn't be here, but she's interested in, and I think you've touched on this, but I just wanted to make sure that her question was represented. But she's interested in knowing how you navigate challenges with health literacy, because that's something her medical school is really focused on population health. And because a lot of your patients are low socioeconomic status and a large portion are immigrants who might not speak English well, how are you able to effectively communicate certain medical topics?
Yeah, I think it's a great question. I'll tell you a way that I really failed because it was recent. I have a patient who, what was it? I forget what we were trying to send her, but everything's on the electronic health record, right? And there's a little icon that lights up if they have access to their portal, and hers wasn't lit up. And I don't know, I think I was just sort of spacing out for a minute, but I was like, oh, we need to enroll you in my chart. And she just stopped me in my tracks and she said, hello, are you listening? I don't read, remember? And I can't, even if I could, my eyesight is so bad that I couldn't see it. And like in a flash, I was like, oh yeah, I forgot. And I was so glad that she had the wherewithal and the confidence to just call me on it. Like so many of our patients don't read English or don't read technology. Like they don't have access to technology. I mean, there's so many barriers for patients that we forget sometimes, and we need to remember. So of course you can't enroll on my chart. Like my chart has no meaning for her. Also, she doesn't have a cell phone. So, so often we're just definitely not all patients. A lot of my patients do have cell phones and are more technologically savvy than I am. So it's not necessarily a blanket assumption about vulnerable populations, but there's so much difference. And I think it's really important to ask patients, like, how do we best communicate with you? For a lot of our patients at Maxine Hall, it is old school. It's with a conversation and sitting down together, preferably in the same room. I mean, I know a lot of systems are doing a lot more video visits than we are, but it doesn't work for a lot of my patients. It's just too frustrating. And so they like to come in. They like to have conversations in person. So I'm glad we're, able to do that with them.
Yeah, that's a really interesting story, and I'm glad you're willing to share about a time that you fell short, because I think not a lot of people are humble enough to do that. So,
it's a frequent occurrence, so no problem.
I'm wondering, this is a big reason why I wanted to bring you on, is because you are a great model of faith and medicine intersecting. And as a Christian myself, that's something that I want to emulate when I go into medicine. So I'm wondering, if you could touch on how your faith informs your approach to medicine and how you're able to integrate your values and your spirituality into your clinical work, because I know it can sometimes be a fine line, and I'm sure it's an even finer line when you work in public health and you represent the government.
Oh, sure. Yeah. It's been quite a journey for me. I know you know some of this, but yeah, I took a sabbatical, gosh, maybe like 10 years ago now, where I felt pretty burnt out before that sabbatical. I kind of felt at the end of myself. And I think in my generation of training, there was probably too much, or maybe this is still the case, I don't know, expectation around being the hero of, in my day, there were no work hours restrictions. You just worked until you either collapsed or, it was not good. 80 hours would, that was too limiting, too low for us. And yeah, so by the time I took that 3-month sabbatical, I felt pretty low power mode, and it was really helpful. I going through a process of spiritual direction, and I think a lot of time of just personal reflection and prayer as well, where I felt like I needed to have a shift in perspective where I was not the hero, and I was not trying to be a savior in the room with my patients. But I needed to make room to invite, to me, it's Jesus or the Holy Spirit, or God, into the room with me and my patient. And so that we could both be tended to. And that was a game changer for me, to have turned to another source of strength, because I felt kind of at the end of my rope and the end of my own personal strength. So I think that perspective has been pretty altering for me and has probably opened the door to bits of humility as well, where it's too threatening to kind of be humble if you're also supposed to be the savior. It just doesn't work. So, but I also feel like I'm growing more and more lately I'm kind of into the recognition that there's just a lot wrong with medicine. I think a lot of our mindset around scarcity and ways that we kind of come up against the patient, even a lot of the wording that we have in medicine, the patient has complaints. We often disbelieve our patients. So I think I'm coming into more awareness around, like, medicine is a flawed field, and in a lot of ways we're set up poorly to partner with our patients. And so I feel like I'm asking God about that nowadays. How do we do this if we're set up so poorly for it? The electronic health record is just spitting more and more data and washing it over us. I don't want to be looking at that all the time. Like, how do I remain with my patient when it also needs to be remaining for a maximum of 15 minutes? Like, what are those boundaries that I want to push up against and say, no, we're going to take 30 minutes today or 40 minutes or whatever it is? Or what are those boundaries that I want to be fluid with? What are those spaces where I need to just remain with the patient and invite God into that space?
Right.
What are you know what I mean? Like, so I feel like the questions continue. I definitely don't have it figured out. I'm hoping you'll figure it out, John, you and your generation.
I'll ask.
Yeah. And let us know.
I'm wondering if there are any points where your faith and your professional responsibilities might come into tension. And if they don't, then that's completely fine too. You can just, but I'm wondering how you navigate that, if there are any points.
Yeah, it's tricky. And I think there's lots of gray zones amongst Christians. For example, like a lot of Christians have ethical differences around end of life care, for example. And I've had to prayerfully consider my own stance and path on that. I'm a huge supporter of palliative care and hospice, for example. Thus far, I have not prescribed medicines to end a patient's life at their request. So that's where I have drawn that line. But I know Christians have drawn it in different places. I have referred patients for pregnancy termination, and I know lots of Christians would probably not. So there are ethical areas where I think it's important to wrestle. And yeah, I mean, those could be podcasts in and of themselves. Yeah, but I suppose I would say one Christian to another, please wrestle, please engage with God, and with other people, with other Christians and other healthcare practitioners. I think that's important.
Yeah, that's a really eloquent answer. I'm not sure I could have said something better. But I have some quick questions now, since I know we're running out of time.
Yeah.
So you can keep this short. Do you have any funny stories from your practice that show off I guess, what keeps you doing it? Any funny patient encounter? I'm putting you on the spot here, so.
Yeah, it's not that short though. Is that okay? I'll try to make it short.
I have all the time that you have, so you're definitely get a tighter schedule than me.
I might have told you this before too, because it's one of my favorite stories. A while back, there was a Russian patient of mine who's become very, very dear. But he's also super frustrating and was yelling at me and was just insisting on a referral to a particular specialist. They kept interrupting me and wouldn't let me finish. Until finally, and I think I did tell you this, I was so embarrassed that I yelled back at him. I just kind of lost it. And at that point, he was like, I like you. I think this is going to work out just fine. And I think he had been kind of goading me until I would yell back. And then he was like, good. That's just how he operates in the world. And I haven't yelled at him since then, because I try to explain that I try not to do that. But he wanted me to yell at him a little bit. So.
Tough love.
Yeah, a little bit.
And then this is my last question. As a primary care physician, since you have experience with all ranges of medicine, right? You're kind of the first stop and you see so many different things. Do you have any pet peeves where you see somebody, doesn't have to be, could be one of your patients, could be just in general, and you're like, wow, I just wish people would stop doing that, like going to a something?
I think patriarchy is pretty insidious. My colleague was just telling me about a East Asian man patient who kept interrupting her and telling her the tests that she needed to order, even though he doesn't know anything about medicine. But I more and more, I think I see it. And that's annoying, because I felt annoyed on behalf of my woman colleague, who's really smart and really knows her medicine, but she couldn't practice it because this Korean guy was just thought he knew better. And so that was annoying.
Yeah, that's a big pet peeve. I'm sure a lot of people have that, and it's going to be a while till we get over it, but
it might be.
Anyway, that's all the time I think we have. So thank you so much for allowing me to interview you. It's always an incredible pleasure because you're a great inspiration to me, and we always have great conversations and I learn a lot. So I'm sure I'll keep reaching
pleasure
out
is
with
mine.
many questions, whether it's a podcast or not, for the foreseeable future, because I think I'll need a bit of guidance. So
Sounds great. I'm here for you.
okay, sounds good. Thank you so much.
Your biggest supporter, John.
Yeah.